Okay, wonderful. Thank you so much for the introduction, Dr. Lang, and thank you also for the opportunity to speak. It's really wonderful to be able to connect with all of you. And so today I'm going to be talking about some of the principles of palliative care and quality of life in brain tumor patients. Of course, this is, a very broad topic, and I think, my goal, at least with this, was to provide a snapshot of some of the areas that are of particular interest or emerging interest in the field as they pertain to patient-centered outcomes and quality of life. Some of the strategies that we're using here to evaluate these outcomes in our patients, and some of the ideas in terms of how this part of the field of neuro-oncology can move forward, and some of the research that's being done in this area. And I think you'll probably see from my presentation that this is actually somewhat in its infancy in neuro-oncology. And so I think there's a lot of potential and work to be done in quality of life and palliative care. So we know that just by very nature of the diseases that we see, that they warrant distinct attention in terms of our understanding and study of how they influence our patients' function and their day-to-day lives. Of course, because of the substrate that these cancers appropriate, they can have significant and very distinct consequences from other cancers that, that other tumor sites are encountering and dealing with. Now, it's important to know that tending to patient quality of life and patient-centered outcomes is actually not only important to us as clinicians, or perhaps I could say it's important to us as clinicians because it's important to patients. So as evidence of this was a particular survey that was done back in 2016 through the National Brain Tumor Society here in the United States, where they surveyed over 1,800 patients who had brain tumors and their caregivers. And they asked them, aside from living longer, what do you want clinical trials to look at? What's important for you to find out when you look at the results of a clinical study? And when you look at what these things are, the first couple things are retaining brain functioning, so looking at their cognitive functioning, and then maintaining their ability to walk and perform their basic physical tasks. And so you can see that their functional outcomes, their overall well-being are important to patients, and it's very important that we include these in our research and our clinical practice. Now, the concept of palliative care is one that has evolved a lot, and we'll talk a little bit about that. Initially, palliative care was really defined as this care that was imparted towards the end of life, that was tending to some of the distinct medical needs and distress that's encountered during that period of the illness. But this definition has really evolved, and increasingly we're learning that's intrinsically linked to patient quality of life and tending to patient well-being and having a holistic perspective on patient care. And so palliative care, really in its current construct, involves psychosocial support, spiritual support, looking at the goals of the treatment and ensuring that we readdress and are on the same page as the patient with respect to the goals of the care, helping determine how they can get care within the community as well, supporting the family, providing support in particular to those that are caring for them, and then also looking at pain and symptom management. Now, in terms of our patients, as mentioned, they really have distinct constellations of symptoms, and we're increasingly learning that they're really unique in terms of other neurologic illnesses as well as other cancers. Not only do they have a lot of the symptoms that are associated with other malignancies, such as nausea, vomiting, and fatigue, but they also have more frequent cognitive deficits, motor deficits, and these also appear earlier. They have a distinctly poor survival outcome, and there's actually more caregiver distress and caregiver burnout as well. We know that in our population, it's not only those patients who have the high-grade gliomas, glioblastoma, who have high symptom burdens. In one particular study where they compared different histologic grades of tumors, they found that almost half of patients with low-grade gliomas reported some impairment in their quality of life, and less than half felt they were able to carry out routine activities as they had prior to their diagnosis. And that's really significant when you think of the duration of illness that many of these patients have. Up to half of them reported having moderate to severe symptoms in terms of their intensity. Many reported over 10 symptoms, and most of these symptoms were distinctly neurological, so different from other cancer patients. It's also important to highlight that symptoms in our patients tend to occur early and the impairment in function tends to occur early. So this is a graphic that was published in Neuro-Oncology a couple of years ago to highlight this, and I think it does it very well, where you can see that patient function really starts to change very early in this illness trajectory of glioblastoma, which is the most common primary malignant brain tumor that we see. And so you see that after diagnosis and with radiation therapy imparted, that there tends to be a decline in their function. And then oftentimes there's some plateau. And then when they recur, you can see another significant decline. And so it's very important that at each sort of transition and as these changes in function and symptom burden evolve, that we're addressing the patient's clinical needs, and we're also addressing what their goals are of their care and what their expectations are of their therapy. So one important tool that we're increasingly use to better understand how patients are impacted by their illness and by the treatments are patient-reported outcomes. So in short, patient-reported outcomes are really assessments that directly capture the symptoms and the reported quality of life of patients without us as clinicians interpreting those symptoms based on their verbal report. So there are various validated tools for different illnesses, including brain cancers, that allow us to capture the symptom constellations, to characterize them, and to evaluate the severity of the symptoms and their interference with day-to-day life so we can better understand what the patient experience is. We know that the patient's understanding of their symptoms and their treatment toxicity can and really should inform our therapeutic decision-making. And it's also important to incorporate these so that we have a better sense of how our treatments not only impact patient survival, but their overall outcome. So in terms of highlighting the significance of patient-reported outcomes, I think it's important to cite one of the landmark studies that was done in this area. So this was done out of Memorial Sloan Kettering, and this was not specific to CNS tumors. It was actually multiple different solid tumor sites where they enrolled patients who were on active anti-cancer treatment, so chemotherapy, and they randomized them to the intervention arm where they had regular patient-reported outcome tools administered electronically, where they asked them a battery of questions about their symptom burdens and quality of life, versus the control arm, which was really, standard of care. So checking in at the time of their clinic visits and us asking how they're doing. And so in terms of the outcomes they looked at the patient-reported quality of life, how often they were visiting the ERs, and their survival. And so what they found was actually very significant. So they found that these patients the patients in the experimental arm where they had the PRO assessments performed had significantly fewer ER visits than those that did not have those tools administered. And also they experienced a greater improvement in their quality of life over time on the study, which is something that's actually fairly atypical for many of our patients who are actively going through chemotherapy. And what's also particularly remarkable is that the people in the experimental arm lived 5 months longer. So this was a statistically significant improvement in patient outcome of survival. And there's multiple theories about why this may be the case. Were they able to identify toxicities of therapy earlier by actively inquiring? Did it facilitate the therapeutic relationship between the clinicians and the patients? Is it that function was improved because we were better able to manage symptoms? And were patients able to tolerate more treatment, and that's why they lived longer? And so I think this really brings to light the importance of routinely inquiring about patient symptoms and quality of life, and emphasizes the potential role for these standardized tools to do so. One of the tools that we commonly use in brain cancer patients, and obviously, I'm biased because I trained here and I work here, is the MD Anderson Symptom Inventory Brain Tumor Module. So this is a tool that takes less than 5 minutes for patients to complete. And basically they ask a series of questions about their symptoms, the severity of those symptoms, and then also how those symptoms interfere with their day-to-day life. And they're supposed to specifically comment on how those symptoms were within the last 24 hours. Now, this is, of course, not the only tool that does this and not the only validated tool in patients with brain tumors, but it's nice because it's actually relatively short compared to other tools and well validated in both brain metastases and primary brain tumor populations. Now, we've actually started integrating this in terms of the care that we provide in our clinics. So one of the programs that was rolled out in our Brain and Spine Center last year was having patients be provided a link to complete this tool prior to their clinic visits. So we have a sense of their clinical symptoms, and any particular issues that are arising before we actually see them in the clinic. And this also gives us the opportunity to monitor their symptom burdens over time. So for instance, this is one particular example, a de-identified example of a patient where you can see there's various questions. For instance, your weakness or tingling, how bad is it at its worst? And you can see the patient goes from a 3 out of 10 to an 8 out of 10. And you can see that there's several symptoms that have increased in severity over time. And so this is just one, tool that we're currently using to try and facilitate our monitoring of patient symptoms and quality of life as they go through the illness trajectory. And then, of course, there's the question of not only identifying symptoms, but how do we actually manage the symptoms themselves? And this is something that, of course, I'm, given the time constraints, I'm really not going to be getting into in this particular talk. There's lots of potential modalities for us to do so. Of course, there's anti-tumor therapies that can have a clinical benefit in terms of symptoms for some patients. And then, of course, there's also the possibility that some anti-tumor therapies do the opposite. Corticosteroids are an important tool that we have to try and manage cerebral edema, but of course they come with their own host of toxicities. And then also something that I think are becoming increasingly important, and we're valuing more and more, the importance of rehabilitation, cognitive exercises and treatment, and then also tending to the psychological distress that our patients and their caregivers have. Now, moving into the topic of palliative care in particular, I think it's important to highlight how the idea of palliative care has evolved. So for instance, here you see the definition from the World Health Organization that was just over 30 years ago, where it cites that it's concerned with quality of life and comfort before death. And then this was revamped just over a decade later, talking about patients who have a life-threatening illness and looking at a constellation of symptoms, including the psychological, the spiritual, as well as the physical distressing symptoms that happen in patients who have these severe illnesses. And so this actually leads into another topic, which is the idea of early integration of palliative care. And so the classical model is really that as patients become more advanced with their cancer, that's when you consider integrating palliative care. It might be when anti-tumor treatment stops or slightly before that, but increasingly there's interest and emphasis on integrating palliative care from the beginning of a diagnosis of advanced cancer. And so that there's sort of an evolution where it becomes of increasing importance with time as opposed to a later introduction of the concept entirely. Now, what's interesting is some of the data to support early integration of palliative care in my mind. So this is one of the seminal studies in this area, which was conducted out of the Massachusetts General Hospital. And what they did was they took 151 patients who had a diagnosis of metastatic non-small cell lung cancer, and they randomized them to either have early palliative care, so basically an early palliative care visit, and then they had follow up with a palliative care team versus standard of care. So the treating team could refer them to palliative care when they felt it was indicated, but they did not have to do it from the get-go. And they looked at various outcomes, which we'll discuss. And in terms of what the palliative care clinicians were told to do, they were asked to focus on quality of life, symptom burden, mood, discussing their overall survival and prognosis, and also to address what aggressiveness the patient would want in terms of the care at end of life. And so what they found was actually really quite remarkable. So you can see that the primary outcome here was the mean change in terms of quality of life index. So this is a conglomerate score between multiple patient-reported outcome tools, and you can see that it was significantly better at the 12-week mark, which was the time of measure for the primary outcome in the early palliative care group, as opposed to those that just had standard of care. You can also see that the patients who had early palliative care had significantly lower scores in terms of the following scales for evaluating affective and emotional distress. So looking at depression and anxiety, they had much lower ratings than those that just had standard of care. And then also what was notable is that those patients who had the early palliative care intervention had less aggressive care at the end of life, and yet they survived significantly longer. And this was found to be a statistically significant result. So once again, this brings into question, what are the elements of palliative care that are leading to these improvements in terms of not only patient quality of life and symptom burdens, but also patient survival. And it highlights the importance of further studying this particular area. I think multiple other studies have also found that palliative care is associated with improvements in terms of patient-reported quality of life, reduced patient affective or emotional distress, reduced ICU admissions in the end of life, reduced healthcare costs, as well as better bereavement outcomes when patients' families are actually queried and studied after the patient has passed. I think it also is important while on this topic to highlight the importance of noting that our patients are very distinct in neuro-oncology, and I think we do warrant distinct study to evaluate what types of palliative care is most effective and meaningful for our particular patient population. And that's actually something that we have ongoing here. We have a clinical trial that's currently enrolling, evaluating early palliative care for patients with high-grade astrocytomas. And then I think when we talk about palliative care, it's also very important to talk about advanced care planning. And so one of the challenges is that there's really a paucity of data to guide advanced care planning. So in general terms, advanced care planning is really thought to be the discussion of what a patient would want, particularly towards the end of life or after they pass. So talking about things like living will, as well as advanced directives, and what are their goals of treatment? What would be a level of disability, for instance, where they would not want to have any more anti-tumor therapy. Now, in reviewing the literature in this particular area, we actually find there's really a paucity of literature or study, I should say, to really direct exactly how these conversations should be conducted, what the specific elements of these conversations should be, and how to sort of optimally incorporate them into patient care. There is a general thought, and there is some data to support incorporating these conversations earlier in the illness trajectory for patients. And there's actually survey data for patients that they actually really benefit, psychologically in terms of having these conversations early. It's actually a relief for them. You're sort of addressing the elephant in the room. And I think finally, one important point to bring up in our particular patient population, and a reason to highlight the importance of studying quality of life and end of life and palliative care, is looking at what the patient and the family perspectives are of how that end of life period is for these patients. So this was a study run out of the Netherlands. So they basically surveyed over 80 patients, caregivers, and families after the patients had passed away from a high-grade glioma. And they asked them to rate the patient's death really on a scale of very dignified to very undignified. And as you can see here, about 2/3 of patients' families rated the patient's death as dignified, but that's still, while that's the majority, there's still a significant portion where their families do not feel that it is a dignified death, which I think highlights the importance of the work we have to do in this area. Now, some factors that were associated with a greater patient-family rating of dignity after death were having better end-of-life decisions explained, having earlier discussions around end-of-life care and advanced directives, having the absence of a communication or a language deficit specifically for the patient, having the patient be deceased at their preferred place of death, so whether it's at home or in hospital, and no transition in terms of the healthcare setting within 1 month of death. So I think this was really just a primer about some of the current literature in this area, and I think moreover highlights the importance of all the work that's to be done in this area. We know that quality of life outcomes are increasingly recognized as valuable clinical endpoints, but also important endpoints to incorporate in terms of research and things that we should be looking at when we evaluate clinical research. They can facilitate the provision of comprehensive patient-centered care to our patients with brain tumors. We do, of course, need to do more systematic and prospective study in terms of the palliative care needs of our population and how palliative care can optimally be delivered for our patients. We know we need to better study the end-of-life period in brain tumor patients because at this time it's relatively poorly characterized. And then, of course, devising optimal models for integration of palliative care and addressing also health disparities in this particular area warrant further dedicated study. So thank you very much for listening. I am happy to take any questions.